Good afternoon, ladies and gentlemen. We are continue to study ophthalmology. Our next lecture is glaucoma. You know, it's a great problem all over the world, and today we will try to speak about diagnostic, management, and surgical treatment of glaucoma. Glaucoma is a group of disorders in which intraocular pressure is right above tolerance limit, resulting in a damage to the optic nerve and irreversible visual field defects. Near 70 million of people have glaucoma in the world. Near 7 million of people are totally blind because of glaucoma. And glaucoma is the second cause of blindness and visual disability around the world. So you can see that glaucoma is really great, not just ophthalmological, but also social problem because blind people is a problem for the social. There are a lot of risk factors of glaucoma. We should speak about general like age. Usually, glaucoma affects adult people or even elderly people. For example, open angle glaucoma, which are diagnosed in 80% of the patient with glaucoma. Usually, open angle glaucoma is appear after 60 years old. As for the race, for the black population, the open angle glaucoma is more characterized. As for the Chinese people, we can often diagnose close angle glaucoma. Family history, of course, it's important because if parents or grandparents have glaucoma, then our patient can also have glaucoma. Systemic risk factors are also essential. High blood pressure, increased carotid blood flow, carotid cavernous fistula, plasma hyposmolarity, hyperbaria, diabetes mellitus. And of course, local factors, which are also maybe the risk factors for development of glaucoma. Increased episcleral venous pressure, blockage of ophthalmic vein, blockage of trabecular mesh, restricted extraocular muscles, pathology of accommodation, myopia is a risk factor for glaucoma, cycloplegic agent which can be used in, in, in different diseases such as uveitis, for example, corticosteroids. Corticosteroids which we use after operations, after traumas. In the case of uveitis, when we use corticosteroids for the long period, they may be the cause of increased intraocular pressure and glaucoma. There are a lot of classification of glaucomas, but usually we divide it on glaucoma, on congenital glaucoma, primary glaucomas, and secondary glaucomas. As for the primary glaucomas, we can divide on primary open angle, primary closed angle glaucoma, and primary mixed glaucoma. This classification according angle depends on condition of the angle of anterior chamber. On this picture you can see open angle, and this picture you can see close angle. All glaucomas and glaucoma is caused by imbalance between aqueous production and aqueous outflow. Glaucoma, if we speak about primary glaucoma, is a chronic, slowly progressive, usually bilateral disease, which is characterized by ocular hypertension, typical visual field defects, and optic disc changes. We call this capping excavation. And pay attention that these three signs was found by Greffe in 1856. But even nowadays, all these three signs are correct. So you can see how great scientist was Greffe. For all glaucomas, three signs: ocular hypertension, typical visual defect, and optic disc changes. And when your teacher during practical classes will ask you what are signs of glaucoma, you should always say these three signs, and you will be correct. On this picture, you can see anatomy of anterior chamber angle, difficult structure which help aquahumus leave the eye. I would like we memorize how aquahumus appear in the eye and how aquahumus leaves the eye. So, if you remember that aquahumus is produced by ciliary processes and enter to the posterior chamber here. Sorry, here. Then aquahumus from anterior chamber through the pupil enter in anterior chamber. Then there are two ways for aquahumus outflow. One way, trabecular outflow. Here, aquahumus look through the anterior chamber, through the trabecular mesh, then Schlemm's canal, collector channels, episcleral veins, and leave the eye. There are, another uvascleral outflow. Again, ciliary processes produce aquahumus. Aquahumus goes through the pupil to anterior chamber, one-way trabecular outflow, and the second way uvascleral outflow. So the part of the aquahumus goes through ciliary body, suprachoroidal space, and to venous circulation of ciliary body, choroid and sclera. Usually, more than 80% of the aquahumus goes through trabecular outflow, and just Near 20% of aquahumors go through US scleral outflow. Okay, so another classification of glaucoma from depending on the anterior chamber angle we have already mentioned, open angle, closed angle, and mixed, and according to condition of the visual field, according to visual field defects. Nesterov and Bunin in 1975 divided glaucomas on stages. The first stage, mm, mild stage, is characterized by scotoma, which develops between 10 degrees and 20 degrees. Mm, The second stage, nasal step or temporal wedge, less than 15 degrees, vision field lost. Uh, the third stage, the visual field loss more than on 15%. And the fourth stage, this is a tube visual field or total blindness. Also, we can classify glaucoma according intraocular pressure. Normal intraocular pressure, the intraocular pressure less than 27, moderate elevation 28 to 32, and high intraocular pressure more than 33. Okay, let's speak about primary open-angle glaucoma. I have already mentioned that near 80% of the patient with glaucoma has primary open-angle glaucoma. Open-angle glaucoma is characterized by open angle of anterior chamber with normal gonioscopic appearance. Chronic progressive loss of retinal ganglion cells manifest by optic neuropathy. Also, for primary open-angle glaucoma is characterized by typical visual field defects, and usually this glaucoma affects both eyes, but rather often asymmetrically. Pathogenesis of primary open-angle glaucoma. The cause, of course, is impaired outflow. Usually, the problem is in trabecular measure, though the sclerosis of trabecula and less fluid can leave eyes through this trabecula. Impaired outflow is a cause of ocular hypertension. Then we can see dystrophic changes. Again, more deep sclerosis of the trabecular measure, chronic ocular hypertension, optic nerve ischemia, then atrophy of the optic nerve, loss of vision, and blindness. As for the symptoms of primary open-angle glaucoma, I would like to say that in early stages, uh, usually there is no any symptoms. So maybe the patient have a slight headache or blurring of vision or colored halos, but it's not a severe situation. Don't forget that primary open glaucoma usually affects rather elderly people, and they sometimes don't pay attention on slight headache or eye ache and to think maybe it's high blood pressure or something like this. And that's why rather often the people with primary open angle glaucoma come to doctors, to ophthalmologists in late stages when we can't help to this patient, and that's why early diagnostic of this disease is a very important part of our work. So let's discuss methods of investigation which can help us to make to suggest glaucoma to make correct diagnosis. What should we do? We can examine the eye by focal illumination, by slit lamp, and make gonioscopy, examine the anterior angle of anterior chamber. What can we see in the anterior part of the eye? We can see symptoms of emissarium of the in the conjunctiva vessels. In the late signs, symptoms of cobra, we can see iris dystrophy and sectoral iris atrophy. On this picture, by the way, you see the head of our department, Professor Ivanova. She is examining the patient. Gonioscopy, I have already mentioned, examination of anterior chamber, uh, angle of the eye. Of course, you know that one of the most important sign of glaucoma is ocular hypertension, and tonometry is one of the most important methods of examination. Usually, we recommend to measure intraocular pressure once a year for the all people after 40. Uh, there are a lot of devices which can help us uh, to measure intraocular pressure. Nowadays, we use tonometry by Maklakov. When we have anything, we have palpate the eye and estimate how hard is it. In European countries very often use Goldman tonometer. And nowadays, we use rather often who have already attended our practical classes and have opportunity to see that we use pneumatonometers. Pneumatonometers use just it's a without contact method, and we can use just in air to measure intraocular pressure. It's good. It's without contact method, but this method is not um, mm, always right. That's why it's more than a screening method. If we see the high intraocular pressure, which we measure by pneumatic tonometer, we can measure this intraocular pressure by contact tonometers, which usually gives us more correct result. Okay, we should also uh, check the visual fields in a patient um, with suggestion of glaucoma. We have already mentioned that visual field defects are very um, often appear in a patient with glaucoma. So there is a control method when we compare the patient visual field with the doctor's visual field, but it's a very simple but rather old method. I hope during your classes in physiology you can use this arc perimeter and can have opportunity to measure visual field. We can use campimeter and we can see nowadays Humphrey visual field analyzer uh, or other devices which can help us to measure visual field using electronic devices. And I would like you to tell some words about visual field defect. Look, it's a normal visual field. Yeah? You can see defects, more defects, severe defects, and just small part of visual field are survive. No, also you can see central scotomas, you can see big central scotoma, you can see tube visual field here also. This result we can receive in modern electronic perimeter, and you of course can see the defects of visual field. We estimate the regional sensitivity to light and look on this picture. Here just increased size of blind spot and central scotoma. But on this picture you can see that just small part of the visual field is survived and other mm, other part of the visual field are blind. Okay, and we should, in a case of glaucoma, in a case of suggestion of glaucoma, examine the optic nerve. Optic nerve we can examine by ophthalmoscopy. It's a rather old method, but still effective, and we can make an examination of the optic nerve using optical coherence tomography. Who was on practical classes, I think, know about this method. I have already mentioned that we usually using ophthalmoscopy, we estimate cup disc ratio in the horizontal and vertical meridian, and it must be 0.3 or less. Here you see that cup excavation increase, here more, here more and more, and here you see that even though the nervous fibers just atrophy. Now on this picture you can see examples um, of cupping excavation of the optic disc in a patient with glaucoma. Look, this, this excavation decrease and deep, and of course, if we diagnose glaucoma in such condition, I think the patient have in such cases rather bad visual acuity and very narrow visual fields. Okay, let's speak about changes of the um, optic nerve and visual field. Look on this picture. here, just first stage, a bit increase the size of blind spot, and here you see excavation a bit increase. Here you see the big excavation, and visual field becomes worse. Here excavation becomes bigger and visual fields worse, and you can see visual field, just the pieces of visual field we can see, and here we have see total excavation. Let's speak about optical coherence tomography. Here you see the macular area. This is a picture of the optic nerve, disc of the optic nerve. Here on this picture, you see the thickness of nervous fibers. Here you see that thickness of nervous fibers decrease. The thickness must be in green area, and if we receive such picture, we can suggest glaucoma. Okay, so we make correct diagnose glaucoma. What should we do? We should prescribe anti-glaucomatosis drugs which decrease intraocular pressure. We should add neuroprotective therapy, and if anti-glaucoma drugs are not effective, we can prescribe surgical treatment. On this picture you can see the groups of the medicines which we use for local treatment of primary open-angle glaucoma. The first line treatment is prostaglandin analog like salaritan, travatan. Salaritan is latanoprost, travatan travoprost. Beta blockers we can use. It's also first line treatment for glaucoma. Usually we use timolol 0.5%. We can also, but rare, uh, can use myotic drugs, adrenergic agonist, uh, and carbonic inhibitors. So some of these medicine increase outflow, and some of this medicine decrease the production of aqua So usually analog of prostaglandins increase the outflow, but um, beta blocks decrease the production of aqua fluid. You can see on this picture just several eye drops which we use uh, for the glaucoma treatment. And you can say, why so many drops? It because of the severity process. We prescribe drops, but not always they are effective. Even every 5 years appear as new drops, but it's a pity. But despite of new drops, despite of new treatment, uh, in some cases glaucoma progress. If the conservative treatment, if the eye drops are not effective, we can add laser treatment. Usually we use argon laser trabeculoplasty to mm, to make incision, to make space in trabecular mesh. In severe cases, we can make cyclophotocoagulation. When eye drops laser treatment is not effective, we should make mm, surgery. Oh, I would like to show you the sinus trabeculectomy. The principle is we make incision of conjunctiva, then near the limbus make the piece of the sclera, and here you see we make hole in angle of anterior chamber to give opportunity mm, for fluid to go to leave the eye. Usually this fluid go uh, under the conjunctiva. Again, you see the picture, you see how to use this. Then we put some sutures on this part of the sclera, piece of the sclera. In severe cases, we put in eye different drainage devices which also help to fluid to leave the eye. Okay, let's go further. We should speak about primary angle closure glaucoma. Primary angle closure glaucoma is a condition in which aqueous outflow is obstructed slowly as a result of closure of the angle by peripheral iris. How it happens? Usually, lens move forward, appear pupillary block, and um, aqueous from posterior chamber can't go to anterior chamber. We receive high pressure of the aqueous in anterior chamber and iris bomb, occlusion of trabecular zone by iris, and mm, of course pressure in the posterior chamber and vitreous body increase. Iris contact with trabecular mesh, and we receive total occlusion of anterior chamber angle. We receive total occlusion here. Clinical feature of primary angle closure glaucoma. There are substages. The first, prodromal stage or latent glaucoma. Each attack lasts for a few seconds. Stage of constant instability. In this stage, attacks of rise of intraocular pressure are recurrent, regular, and each attack may last from a few minutes to 1-2 hours. The third stage, acute congestive stage. Fourth, chronic congestive stage. And fifth stage, absolute stage. There are some risk factors for acute and angle closure glaucoma. These are emotional stress, overwork, dim illumination, mediatic drugs, and anatomical risk factors. These are big lens, small eye, hyperopia. Symptoms are follow pain, it's a severe pain, it's urgent situation, color halos or rainbows, um, blurring of vision, of course, nausea, vomiting, clinical signs, intraocular pressure, usually high during attack. When you palpate eye, it, these are very hard, like a stone, and even without measurement, we can estimate the intraocular pressure. The pupil is dilated. We can see redness of the eyeball, cornea edema, or we can, if we can see the angle of anterior chamber, we see that angle is closed. We can see iris atrophy, posterior ciliary in some cases, and we see the small anterior chamber, and if it's possible to see the optic nerve because cornea is edematosis, we can see the carbon excavation or even optic atrophy. On this picture, you can see acute angle closure glaucoma. Look on this redness of the eye, dilatation of the pupil. On this picture, you can see edema of the cornea. Also, pupil is dilated. Of course, the acute angle closure glaucoma is an emergency case, and mm, the patient has severe condition, and we should hospitalize this patient immediately in an ophthalmological department. In ophthalmological department, we should put eye drops, pilocarpine 1-2% each 15 minutes in the first hour. Don't forget. Timolol 0.5% 2 times a day. We should prescribe painkiller. Um, we should prescribe the medicine which decrease arterial pressure, high blood pressure. We should use systemically uh, inhibitors of carbon hydrase like diacarb, for example. If it's possible, we should immediately to make um, iridectomy. When we make iridectomy, the connection between posterior and anterior chamber reconstructed, and the acute angle closure glaucoma is dissipated. I would like to tell you some words about congenital glaucoma. It's rather, um, it's rather difficult condition, rather dangerous condition. And for example, if you will GP or if you will work with children, you should think and remember about this glaucoma. You should suggest this glaucoma in time, diagnose and help to children. So, primary congenital glaucoma can be divided into the three types: true congenital glaucoma, uh, which appear in newborn; infantile glaucoma; mm, juvenile glaucoma. Clinical features. Of course, newborn can't say you about the pain, can't say about redness, and so on. Usually, we can see corneal haze, uh, so blurring cornea, not fully transparent cornea, and we can see lacrimation, photophobia, and blepharospasm. If you see such um, newborn, you should send it to ophthalmologist. In the late stages, we can see ophthalmos or big eye. We can see glaucomatosis, cupping, excavation of the optic nerve. But the early symptoms um, are rather simple: lacrimation, photophobia, and blepharospasm. And don't forget about congenital glaucoma. Look on this picture. Here you see big eye ophthalmos, yeah? On this picture, you see the cloudy cornea, opaque cornea, and of course, in such case, we can't help to this newborn to save vision. And usually, the treatment of congenital glaucoma is surgical. Before surgery, of course, we can prescribe some anti-glaucoma drops, but it just for the time for the preparation for surgical treatment. I think you enjoyed the lectures. Thank you very much for your attention, and hope we will continue the discussion. We will continue to speak about glaucoma during our practical classes. Thank you very much and goodbye.